Good morning, everyone, and thank you all for joining us today at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Center for Substance Use Training and Telementoring, CSTAT at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. These sessions are enabled for closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on the three dots or More menu at the bottom right of your Zoom screen to access this. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, click on the speech bubble icon at the navigation bar at the bottom of your window. To all the Beeville, Texas providers, please make sure that you identify yourselves during the session by entering your name in the chat, or if you're joining via phone, please email your phone number and email to bevilletx@utisca.edu. Also, please note that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any info you put in the chat will not be shared in the recording. We encourage everyone to join by video, especially for the discussion portion of the session. That said, regardless of how you're here today, we're just happy that you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the reactions menu at the bottom right of your Zoom screen to raise your hand and indicate that you have a comment to share. You can also use the chat to share your questions and perspectives. There are a lot of us in this space, so please keep your comments brief to allow others to share as well. And finally, please note that no protected health information is allowed in either the chat or the discussions, and that includes names, addresses, emails, or any pictures, dates, or any information that can easily identify a person. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it also allows you to access free continuing education credits. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credentials. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Joe Smarro on ACE score and self-assessment for public safety professionals. Following that, we'll hear a case presented by James Perez. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage you all to share that during a discussion so that we can all learn from each other. And with that, we will begin with some introductions. Jeremiah.
Hi, everybody. Welcome to another ECHO session. This will be fun. I'm looking forward to this one. I'm Jeremiah Golka. I'm the Executive Director of the SHIELD Training Initiative based out of Northeastern University. We do occupational health and safety trainings for police and first responders connected to their work doing drug enforcement or drug-related encounters. Glad to be here. Hope you all enjoy it.
Thank you so much for joining us today. Joe.
Hey, I'm Joe Smarro. I'm the CEO of Solution Point Plus, and we're a national training and consulting firm that operates at the intersection of where behavioral health and criminal justice systems intersect. And I'll be presenting this morning's case. I'm excited to be here with you all. Look forward to it.
Thank you so much. Cynthia.
Good morning. Happy to be here. Excited about the next presentation. My name is Cynthia Mendiola. I am a retired federal probation officer. I currently train probation officers in core correctional interventions, and I'm happy to be here. Thank you.
Thank you so much for joining us. And I'm very pleased to introduce Brandon Del Pozo. He will be joining as a new hub. Thank you so much, Brandon. And if you could please share a bit of yourself for our learners today.
Hey, great. I'm so glad to be here. My name is Brandon Del Pozo. I was a New York City police officer for about 19 years. was the chief of police of Burlington, Vermont for 4 years. These days, I am a professor of medicine and public health at Brown University, where I study addiction and overdose, especially the way the police and the government responds to them. And I just got back from Texas. I try to make it there once or twice a year. I went to Austin, San Marcos, Corpus, Dallas. And right now, I won't show it to you, but I'm wearing a belt I bought at Cavender's, a Texas belt. I wear it every day, even when I'm not at these meetings with Texans. So excited to be here.
Thank you so much for joining
Oh.
us, Brandon. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler. I am one of the program coordinators here at the Center for Substance Use Training and Telementoring, a division of Be Well Texas at UT Health San Antonio. We currently have 8 different training series. Each one of them addresses a different aspect of substance use and substance use disorder. And I am very proud to be part of this team. Thank you.
Thank you so much. And James Perez.
Hello, everybody. James Bettis. I'm with San Antonio Fire Department. I'm currently with the EMS division right now. On top of that, also just kind of like a reservist for the MIH field that we have here. So I'm kind of familiar with some of this overdose prevention stuff that we're working on. But my main job is with 911 ambulance transport.
Thank you so much for joining us. And with that, we will move on to our didactics. Joe, you can take it away whenever you're ready.
Thank you, ma'am. All right, so I want to be very mindful of time in the case that's going to be presented today. This is typically like a 75-minute block that I'm going to try to do in 24 minutes. So real quick backstory before we jump in, and the disclosures of it's important that we have this and see this, but all members of the planning committee have no relevant financial relationship with commercial interests to disclose, and the views and opinions expressed by participants and speakers attending the ECHO sessions are solely opinions, do not reflect the official position or policy of UT Health San Antonio. We're going to talk about fundamentals and implications of ACE scores, apply ACE insights to improve self-care resilience among first responders, and then emphasize empathy and the importance of supportive interactions with community members and colleagues affected by trauma. So I know that ACEs has been around since '91. I'll do a real quick high-level background on this. Sadly, I didn't learn about ACEs until 2017, but it was one of those like 1-degree shifts in my life when I went through it as a first responder, because something I didn't mention in my intro was that I did 15 years with the San Antonio Police Department. In the last 11, I did full-time on the mental health unit. And so prior to leaving in 2020. And so when I went through the ACEs training in 2017, I was like, wow, like one, how did I not know about this as a mental health officer? But two, I really thought it was important that every first responder should be made aware of this. And now as someone that travels around the country providing training, it's very rare when I'm training a group of first responders that they even know what this is. And so again, because it was super impactful in my life, I've seen the impact it's had on others. I actually provided this training to all 2,400 members of the San Antonio Police Department, and the results were staggering. But I went just beyond like looking at what the score is. I looked at really what does that mean? And I am taking some liberties here because I also am aware that there's some issues with the original study that Dr. Zanda and Folletti did. I know that it was back in 1991. It did receive funding by the CDC in '94, but what they were looking at is anything prior to this in public health, which is really what we're talking about. Things were based off like a 1-to-1, right? If Jeremiah, for example, was physically abused as a 9-year-old child, could we predict with any relative certainty that he would develop COPD as an adult? Well, that's incredibly difficult to do, right? And so they said, let's look at clusters of trauma and see if we can predict clusters of or potential outcomes of behavioral impact, again, under the public health umbrella. And the results, again, were pretty staggering and spoke for themselves. But what I found interesting on their sample of 17,000 adults ages 19 to 94 is that most of them did have college education. Again, there's an argument that their original sample lacked appropriate diversity, that it was kind of a focused group within maybe Kaiser Permanente, and there was some attachment, and that it didn't have a full diverse scale. But Again, I'm going to take some liberties just about what I've seen this do in a lot of first responders. And then 6% of that size did not graduate high school. And real quick, I want to just say that nothing that I'm going to say right now is with the intention of activating anybody. But I'm also very aware that if you are someone on this call that experienced childhood trauma, which by the mere nature of the profession you have, it is very safe to assume that approximately half of you have childhood trauma or more, at least 4 on this assessment that we're going to take, because that's what the data tells us. Now, if you have not thought about, dealt with, received professional treatment or therapy for trauma that you endured as a child, and you've kind of suppressed it or compartmentalized it the best you think you can, and it's never really come up, again, there's a potential that in just learning about this and thinking about these things, that something could stir up within you. All I would offer is that you honor that. Remember, emotions are the language of the subconscious. And so if you're feeling something, pay attention to your body and please seek any help or resources that you may need. So they looked at 3 categories. We have abuse, neglect, and household dysfunction. Physical, emotional, and sexual abuse, physical and emotional neglect, and mental illness, incarcerated relatives, substance use, divorce, and then a mother treated violently as what they were studying. And then on the outcomes of this, the impact on the behavior, we have physical activity, smoking, alcohol, drug use, missed work. And then on the physical and mental health side, again, we've got all these things that you can see here. Now, it's super interesting as we look at this one slide. We look at this and we can just see that these are issues that, again, significantly impact any community, from public health to hospital systems to criminal justice systems. In fact, what we know is that a vast majority of our inmate population in prisons in the United States have a very high ACE score. Over 80% of prison inmates probably have a 4 or higher ACE score. And there's also a very fair percentage of roughly 50% that have a 4 or higher ACE score. And so what that tells me is the impact of unprocessed trauma that leads into behaviors that are going to potentially interface you with the criminal justice system and or the treatment systems with fire EMS and substance use and the things that we're actually going to talk about today. I think that all human behavior is communication. And I think that especially any type of adverse behavior, if anything we're looking at on this slide specifically, typically, not always, because nothing's a 1 in social science, it's like a big neon sign pointing to some level of trauma, most often unprocessed. So what's the point? The higher your ACE score is, the higher the risk for negative health and well-being outcomes, meaning the higher your score is, the higher the risk for you potentially to deal with something on that previous slide. Again, not a guarantee. But what I found interesting too in reading about this is that they estimated 50% of what they deemed helpers and protectors, which I argue is everyone on this call, not just police, fire, and EMS, but social workers, clinicians, corrections, probation, dispatch, military, nursing, anyone that's in the helping and protecting profession, roughly 50% of them have a 4 or higher ACE score, which again, to me, you can just think about that as like, oh, that's interesting. But I think there's a reason why we do anything as human beings. And I think there's a reason why we as human beings self-select into the professions that we do. There's a reason behind why, other than just like a random passion you grabbed out of the sky. I think there's a reason why we are pulled or drawn towards specific things. And I think the professions that we're all in on this call, there's a bigger reason for that. They're also highly interrelated. They found 87% of people that had 1 ACE score had more than 1 ACE score. So 13% of the population would have 0 or just have that 1. Question number 6, all the questions are prior to your 18th birthday, but question number 6 is, were your parents ever separated or divorced? And so maybe that's the only one you have. But again, it's pretty rare just because we know how contentious divorce can be with people. And so typically there could be an opportunity or potential for there to be other trauma factors with that. And again, as I show you this assessment here shortly, you'll be able to see it and take it. And then I want to talk about why that matters. I also love this slide, intergenerational transmission of household dysfunction. So this to me is super interesting because again, I think it tells us a bigger story as to why the problems are the problems. right? Why do people use drugs? Why do people become houseless? Why do people get involved in the systems? There's so many reasons and factors behind all of this. And I think we don't necessarily do a good enough job, very broad stroke brush here I'm painting with, in policing especially, of being really, really curious as to what's behind the behavior. We kind of can fall into the trap of just seeing the world as black and white, especially as a law enforcement officer. There's a law, you broke it, I'm here to enforce it. But the world is far more complex than that. Human behavior is far more complex than that. And I pride myself in my career as a police officer of being very curious. I had a mantra: focus on the person, not the problem. Every time. It didn't matter what I was there for. The problem will come up. I know what I tell people is the problem is what gives me permission to have my purpose. That's how I view it. But I see so many first responders that become frustrated with people's problems. People get frustrated about having to deal with the same person. People get frustrated about, like, oh man, I keep putting this familiar face. We deal with them all the time. But I find that if we find ourselves becoming frustrated, it's typically because we're not curious enough, and we're falling into the trap again of looking at things through the systemic lens, and there's going to be issues with all of that. But if a child is born into a home where there's addiction, violence, mental illness, suicide attempts, or someone that dies by suicide, parental discord, divorce, separation, abandonment, or incarceration, we live in a society that just has this blanket expectation that once you are 18, 21, whatever it is, that you should just have life figured out. And I think it's a really unfair expectation. I'm not surprised that the number 1 and 2 diagnoses worldwide is anxiety and depression. I think there's a lot of reasons for this. I don't think we do a good enough job preparing our children for adulthood in the country. I think public education plays a big role in this. And anytime you have standardized training and curriculum that's benchmarked against scores and tests, we're missing huge opportunities. And then when people get into the world, realizing things are expensive, I don't know what my real calling or passion is. I go to school, but I come from very difficult background. It's going to be harder. And that's an aside from the fact that we know trauma impacts the brain, the physiological development, not just the language centers in our brain, but even the development of our brain, what trauma does over time. There's all kinds of studies and PET scans and MRIs to show the difference of a healthy brain versus a traumatized brain and what that looks like. And I assure you it has behavioral impacts on it. When we talk about toxic stress, and I apologize for flying, again, I'm trying to stay in my time here, but frequent or prolonged exposure to ACEs can create toxic stress, which can damage the developing brain of a child and affect overall health. We talked about this, right? Toxic stress being cortisol. Again, I think in a lot of our professions on this call as first responders, I tell people that this is why I do so much work on the wellness side of we like voluntarily induce cortisol because we stay stressed out, not just on duty, but off duty. We're not doing things that we need to do in between calls, in between cases, in between engagement, in between patients. We're not doing box breathing. We're not doing anything to regulate our systems. We're just kind of staying amped up. And then you get off duty, and maybe you married another first responder because the brain craves familiarity. And so then you go home and just talk about work, and you never really get to turn it off. And I think the problem with this, especially if we know that 50% of helpers and protectors have a 4 or higher ACE score, we also know that there's a massive gap in first responders actually receiving treatment because we somehow adopted a belief that we're supposed to be better than and that we're immune to suffering. And so we don't really get treatment for ourselves. And then the job is going to create trauma for us on multiple levels. And so now we have childhood trauma coupled with, I'll give you my case, childhood trauma coupled with, because I'm a decorated combat Marine, coupled with combat trauma, then get into a police department in a city, coupled with trauma within the job. Then I get on the mental health unit and deal with a lot of trauma and suffering and people that die by suicide and everything that goes along with that. And I didn't get treatment until I had 2 years into the mental health unit when I was at a very, very dark place and realized, like, I've got to fix this because I'm making an absolute mess of my life. And I've been actively engaged in treatment for 14 years now, but it's done a huge, huge blessing for me. I've learned so much about my own self, my own history, a lot of this stuff that we're talking about, and then how that shapes the way I view and the lens that I have for people in the world. And I've had to do a lot of work to overcome some of these things. If we were to prevent ACEs in future generations, again, just look at this quickly, but we could essentially limit lifetime incarceration by 65%, teen pregnancy 31%, violence perpetration could go down 60%, victimization 57%. Essentially, the world would be a much better place if we addressed and dealt with trauma. Something that I kind of say tongue in cheek, not to be offensive, but what I say is it would be awesome if every time, a woman's at a hospital giving birth to her child, and they, take the baby and throw it up on your chest for some skin to skin time, and then they take it away to go and weigh it and do all the things. In that moment, if like a nurse would come or a clinician would come and just present to you the ACE assessment and just say, hey, here's some information. Let's just be mindful of the life that we're about to create or have or present to this child. And because I think education is key. And there's a lot of people, again, even in our own world, that are very unfamiliar with this one thing. Again, understanding that this isn't the silver bullet or the solution to all problems, but it's still information that tells us a pretty good story. I mentioned this. Why does it matter? It's very popular. And so I want you to do two things. The first is I really want you to consider what your score is for every encounter going forward. And then I want you to consider what the score of the person you're helping could be going forward. And then maybe that's an opportunity for us to see and think differently. Because I will tell you again, as someone that has a high ACE score, this matters a lot to people and your willingness to not only see other people, but allow them to see you in return. And what I call minimize that delta between who they are or where they are and who you are and where you are, even if it's real or perceived, but that like authority and power we have over people, how can we minimize that delta to, again, create a human experience? And so we've heard this is a brilliant cartoon, right? We can lead a horse to water, but what? We can't make it drink. Beautiful. That's not our job. I know we have a very diverse group on this call, but I heard this many years ago, and I would love for you guys to entertain this. But our job should not be this is the equivalent of I can lead a person to jail, but I can't change their behavior. I can lead a person to a hospital, but I can't make them take their medications. I can take a patient to sobering or detox, but I can't force them to stay through their program. And so our job is not to lead the person to whatever resource and make them do anything. Our job is to make the horse thirsty. And I think if we can make the horse thirsty, a thirsty horse will find its own water. And so for us in the realm of people, this was what I did in my profession. This is what I do now as a speaker and a trainer, is I try to make people thirsty. And if you're thinking for what, it's just for more, for better, for different, for the next level, for whatever they can. And we, on this call, the positions that we're in, if we can just spend time trying to make the people that are in our purview and in our sphere of influence, if we can make them thirsty, then they'll want to maybe start helping themselves. And I get that that's simply stated, but it's just a different way to think about it. So let's really quickly go through this again. I think it's important. A lot of people that I've met that have been through ACEs training, they never took the assessment. And it's important for me that anyone I talk to about this, take the assessment and actually know what your score is. Everyone on this call, I imagine, is over 18. So your score is fixed. It does not change because you're over 18. But don't just have the number and then be like, oh, I'm a 6. And that means nothing. But I'll offer to you why I think it's important here at the end. Also, this is not all encompassing. Please, please, please hear me out. If you went through something traumatic as a child and it's not on this 10-question assessment, that does not minimize the trauma you went through. It doesn't mean yours doesn't count. Yours absolutely counts. All right. Nobody gets to tell you what you went through was not traumatic just because it's not on this one assessment. All right. So 10 questions real quick. Prior to your 18th birthday, did a parent or other adult in the household often swear at you, insult you, put you down, or humiliate you? Or did it act in a way that made you afraid of being physically injured? If it's all of those, guys, it's just one. If it's just one of those, it's still just one. Dude, did a parent or other adult in the household often push, grab, slap, throw something at you? Or did they ever hit you so hard you have marks or were injured? 3, did a parent or other adult in the household 5 years older ever touch, fondle, or have you touch their body in a sexual way? Or try to, or actually have oral, anal, or vaginal sex with you? 4, do you often feel no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close, or support each other? 5, do you often feel you didn't have enough to eat, you had to wear dirty clothes, you had no one to protect you, or your parents were too drunk or too high to take care of you? 6, were your parents ever separated or divorced? 7, were either your parents or caregivers pushed, grabbed, slapped, had something thrown at them, or sometimes kicked, hit with a fist or a hard object, or repeatedly hit for a few minutes, or threatened with a gun or a knife? 8, did you live with anyone that was a problem drinker, alcoholic, or used street drugs? 9, was a household member depressed, mentally ill, or did a household member ever attempt or die by suicide? And 10, did a household member ever go to prison? Now, real quick, Shreya, will you give me a time check? Am I out of time? Do I have a couple minutes? Where am I at?
Just about a couple minutes.
Okay.
We're good. Yeah.
All right. So let me just first of all, please again honor your number and what that means. I will tell you that I am a 9 personally, and I'll just give you this real quick high level story to explain why this work matters so much to me. My parents married young, straight out of high school. I have a sister who's 3 years older. My father was in the Navy. He went on a deployment. He was gone on a routine 6-month deployment. My mom started having an affair, and the guy she was having an affair with, another sailor, started sexually abusing me and my sister. And this went on for a while. And I ended up telling my mom what happened. She told me, no, it's not. We don't say those things. Okay. I'm 7 years old at this time. And so what is a kid to do? Right. So the abuse continues. At some point, I'm on base housing in Virginia. It's a weekend. My sister's in the bathtub. My mom's sleeping on the couch, taking a nap. And she used to be a smoker. And I got a book of matches out of her purse. I laid underneath my bed and I was trying to set my bed on fire. Eventually it caught. I rolled out scared, banged on the door, told my sister there's a fire, woke up my mom. The base fire department showed up very quickly. They put the fire out. It didn't burn the house down. It just charred part of the floor and the wall. And what happens next is super important in my life. The firefighter came out, and this is nothing. I love firefighters, EMS. I hope this guy had a great life and career. He didn't know any better. And I genuinely believe that most all people are doing the best they can with what they have based on what they know. But this fireman came out to me. He leaned over real stern and he said, young man, if you ever start another fire again, you'll spend the rest of your life in prison. Do you understand me? I started crying. Now I want to pause right here. This is why the work that we do is so important, all of us, because how quick are we to sanction and punish human behavior without being curious as to what's driving it? I would have loved the opportunity if this fireman had the insight to say, we've never been to this house before. Surely this isn't a 7-year-old arsonist. Let me pull him to the side and say, hey man, what's going on? What are you trying to tell us? Because all behavior is communication. So is there something that you're trying to convey? And instead of being offered help or hope, I was threatened. And I think this is just a good lesson for parents, for anyone that's in charge of people as leaders. There's so many things we can take away from that. And so sadly, because it wasn't addressed, the abuse continued. And eventually my sister called my grandmother, told her what's happening. She called my father. My father came home and everything just absolutely blew up because he ended up fighting this guy, stabbing the guy. And so then I didn't go to school my 3rd grade year. I was in a therapy and all this stuff. But then I just went through life. I left home at 15, had a kid my senior year of high school, joined the Marine Corps because of that, get deployed to combat. I've been a passenger in my life for so long that it wasn't until I started getting help and learning about all this stuff where I was like, whoa, and I had all these breakthroughs. But I'm super, super aware and have the insight to know that I'm so blessed that I never fell into the trap of substance use, which is so much of what we talk about in this echo. And I have so much empathy and compassion for the people that do, because I see how easily that could have been me. And I made a lot of poor choices. Again, women was my drug. Like I have a lot of divorces. I have 4 kids from 3 women, and I had a huge impact on my life behaviorally. But because it wasn't a law to do what I was doing, there was no crime and punishment. And it was just a moral failing, right? But I could have easily substituted women for drugs or alcohol and been one of the case studies that we talk about on these calls. And so again, that is the reason that this work is so important to me. And then the last slide here is, I call this the unfortunate family tree. If we just look below the surface at the root system here, this can be a house, a community, a neighborhood, a zip code. It can be a myriad of factors. But the reality is the single biggest predictor in our country, in the United States of America, to predict the future success of a child into adulthood is based on their zip code, which is super unfortunate because it's an arbitrary boundary line that predicts so much. But if the root system of a community is built on poverty and discrimination, disruption, a lack of opportunity, and poor housing and violence, then what it's going to give birth to, if you will, is all the things that we deal with and talk about across the entire spectrum of this call. People are interfacing with or touching certain points of what's above this. And instead of, again, being frustrated by it, maybe we can look deeper and be curious enough to see what's under it, what's driving all of that. And then maybe there's a better opportunity to help and serve there. I like using the ACEs concepts for insight. to say, what does this say about me? And the last thing I'll say is, if you took the assessment and you have a 4 or higher, which is deemed high by Dr. Zanda and Felitti, and you've never been in treatment or therapy or professional help, then with all the love I have in my soul, you're wrong. It doesn't go away. You can't out earn it. You can't outperform it. Please do something with it. I love y'all. That's my time. Thank you so much. And I pass to you, Ms. Astria, so you can move on to the next portion.
First of all, thank you so much, Joe, for this wonderful presentation and for sharing your powerful story. I may have a couple minutes for any questions our learning community here might have.
Yes, hi. I have a question if I can. Hey, Joe, big fan, long time. Haven't seen you in a while. I see you're still out there and rock and rolling. I'm a provider at the Center for Healthcare Service, working on detox and mental health facility. And Joe, I wish we need a whole week of you. I'm sorry that you had to go through. You have so much information, so much knowledge. Thanks for sharing. My question to you, what caught my attention, if I may, since we're time limited, it's about the ACEs. I do understand the value of that and predicting values. And you mentioned about, which I never thought about, the ACE that we experience can become the ACEs of the next generation. So when you deal with patients, if that's what you call them, or your people you come in contact, it's what do you use to help prevent that? Or I mean, without saying, hey, if you don't stop being so angry with your soon to be ex or in divorce, your children are to be affected. It's hard not to put a guilt on them, but how do you bring that forward to them? Because we're supposed to be better for our children, kind of thing. Maybe, but maybe they don't think that way. So thank you again, Joe, for an awesome presentation. I was curious as to your thoughts.
Yeah, thanks, Brian. And I dealt with this a lot when I was doing this job. And I think, again, it's all in your approach. I think tone matters so much. You know, if you understand Dr. Moravian's theory of communication, 7% is content, but 55% is body language, 38% is intonation. So it's all in the delivery of it. I would never do it from like a place of judgment or like, hey, do you realize what you're doing to these children? But just, hey, listen, are you familiar with the ACEs interface or the ACEs training? And most of them are going to say no, and I'll just put it on a card and say, hey, when you have time, I would love it if you would just look into this yourself, Google it, take the assessment, and just kind of see what's coming up for you. And then I always offer resources on the backside of that too. What I don't love is when people are like, just look at this. Someone takes that assessment, like, okay, I'm an 8, so what does that mean? Well, that's where they're going to need some hand holding and guidance and referrals. And I think it's super important for parents of children, but even for us, not to just think externally, but to first think internally. Again, everything I do is introspection first. It's like, how does this impact me? What does this mean to me? And then how can I be a positive mirror for the person I'm dealing with? But so I can try and like mirror those wavelengths and get them onto mine, because I've done the work to now where I'm quote unquote healthier, and I want them to match that. So it's just in the approach of how you offer up as like almost as an option, and like, hey, look into this. I would love to follow up with you or talk to you about this, versus you need to do this because what you're doing to these children is wrong, where people are immediately going to get defensive. That would be the best way to go about it.
I appreciate it. When you could come by for a visit.
I'll come, Brian. It's good to see you, brother. I promise.
I'm here Monday through Friday, brother. Hoorah, devil dog.
Raw.
I have I guess a comment or maybe a question. I have a comment or maybe a question, Joe. You know, as I was looking at the, all of the different areas, there's just some things that you can't help, like divorce and separation. I mean, even if you, let's just say, even if you say, okay, I'm not going to get divorced, I'm not going to get separated, I'm just going to deal with this, there's still some kind of trauma that's going to be occurring from even that choice.
Yep.
And it's almost like everything in our life creates trauma. Am I missing? I mean,
there's a psychologist that I like to learn from is Dr. Susan David, and she has a quote that I love. And she says, "The price of admission for a life well lived is suffering." And that doesn't turn me off at all. I think it's a brilliant quote. And yes, I think especially now we're in a very interesting age. We know 53% of marriages end in divorce, and roughly 20% stay together for the children or finances. So we have about a 75% failure rate on something that, again, is perpetuated and promoted. And there's almost shame if people are not. But with that comes children. With that comes a lot of opportunity for suffering. And that's just one aspect of it, because you're absolutely right. It's this cycle of, And this is why I genuinely believe, like, I tell people, I knew every time I was doing something wrong, it was wrong. And a statement I didn't make because I'm not teaching the full class, but I think is important here is, and I would love for people to remember this, because we deal with a lot of traumatized people. Trauma doesn't create an excuse of knowing right from wrong, but what trauma does is it creates apathy towards consequence. And if I have a lot of trauma, then of course I'm going to interface with law enforcement or use drugs or get in trouble or get jammed up, because it's a form of self-sabotage. So if I don't love myself, if I'm very insecure and I don't believe I have high self-worth, then I'm going to do things that are going to validate the way I feel about myself. And so that just becomes a perpetuated cycle, which sadly, again, fills up our systems to where they are now. And we're trying to find out better ways to deal with all of this. So you're spot on, Cynthia. Life is hard. And when you bring more people together, there's a lot of just differences and nuance that create complexities that, and again, not enough people are educated on this.
So
Like, people
that's
don't
what, that's
understand it.
that's your key. The key is you need to get educated, you need that information, you need to seek help. Or
Yes.
to deal with it and recognize it.
Yes. Yeah.
Awesome.
Yeah, which is what I love about the echo, because we've all heard knowledge is power, but I think that's an incomplete sentence. Like, knowledge is power when shared. If we don't share it, right? And I think we don't do enough on a community-wide base. Like, we don't have enough like community interventions and community offerings to give seminars, to invite people in. And, we're always targeted in who we're doing, but we really need to do a better job, I think, globally on addressing the entire spectrum of mental health and substance use, but to make it more like, I'm talking through TV shows, through social media, through multiple deliverables, so that everyone has a base knowledge. Something I used to, when I was touring for the documentary that came out, they would say, Joe, what would you change if you were in charge for a day? And I would always say that, like, when before you get your driver's license, or before you're able to vote, or before you can drink, or whatever, 16, 18, 21, doesn't matter. But to me, it should be a mandate that every American citizen has to go through at least the 8-hour mental health first aid. That should just be a standard practice, that it should be mandatory to give everyone just a basic introduction. I think that would also reduce calls to 911 because people would be less scared to approach people in a mental health crisis the more we understood it. I think it could really help deal with that. So yes, Cynthia, I love your insight and question.
Thank you so much, Joe. This was a wonderful presentation. Thank you again for sharing your story and your wisdom. With that, we will move on to the next part of our session. Karen, if you could please bring up the announcements from BVAL Texas. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive expert feedback from our hub members. There is no need to prepare a formal presentation. We will provide a case form to assist you with your case preparation. If you're interested, please email us at cstat@ithaca.edu. Next slide. Join CSTAT for the third session of our new webinar series, Implications of Long COVID in People with Substance Use Disorder. This will be on Tuesday, March 26th at 12 noon Central. To learn more about our webinar series and to register for this session, please visit cstat.utisca.edu COVID-19 webinar. And we are dropping this link in the chat. Next slide. Join us for our next session on Thursday, April 11th at 11 a.m. And we'll be talking about occupational safety and stimulant-involved encounters. And with that, we will move on to our case for today. Karen, if you could please bring up the case form, and James, you can take it away whenever you're ready.
Hello, everybody. Again, my name is James Bettis. I guess first I'll ask you to bear with me. I'm more of a field kind of guy than an office kind of guy, so I'm new to presentations and giving them in front of people. I also want to just say real quick, Joe, that was an excellent presentation. It's probably my second or third time getting to hear you talk, and it's extremely informative every time, so thank you so much for that. Okay, I guess we'll get going. Like I said, I'm a paramedic. I'm on an ambulance kind of role, and wanted to kind of give to you guys a case of that we had recently. That we work with people who are overdosing in withdrawals often. This particular case is unique though, because this lady was in precipitative precipitated withdrawals, which was a little bit different. So just kind of going down the line, questions that could possibly be addressed. Are there care plans in practice for patients in withdrawals to receive urgent care and be diverted from hospital ERs, just kind of keeping them out of the actual ER count and getting them in the right place sooner? And then also, what is the best patient care practice for a person in precipitated withdrawals post Suboxone treatment? Those are kind of things we just kind of want to look through, I guess, as we're going through this. Some settings and context to kind of give a little background. EMS, we were dispatched for what we thought to be or what was told to us to be a psych patient at a behavioral health detox facility. While I was responding to this call, I heard the fire unit that was on scene. They were talking over the radio to one of our MIH leads about they're trying to understand why this patient was, or why they called 911 for this patient, why we were getting called, why they didn't just get admitted to the facility that they were at. The patient was treated with buprenorphine earlier in that day, went into precipitated withdrawals and was provided transport to that detox facility. But the entrance staff there kind of thought it was more of a psychiatric issue, so they denied her entrance and called 911. EMS clarified, or I clarified the patient's care plan with first responders after I had talked to the MIH lead to kind of figure out on the back end, you know, what was going on and why we were there. And once I figured that out, like I said, kind of just dispersed that information to the fire crew as well as my partner. We did what we could for the patient, transported to the hospital. We ended up passing a few hospitals to go to a specific hospital that has bridging programs with further care facilities. And so that kind of became an area of contention as well while we were passing hospitals. We'll get into that a little later. Once we did get to the hospital and given the missed report to the nurses, they kind of weren't happy that we bypassed everyone and went to them. They were, I guess, fairly busy at the time and didn't understand what their role in all of this services were and that they were the best choice for this hospital. So some of the nurses were kind of challenging me on why we ended up going there. But they ended up taking the patient in, and the doctors who came in later, I'm told, kind of knew what was going on and were able to get her into the right situation. So the brief description, patient was sent to the behavioral health clinic because she was on methadone, and she was being transitioned in the field over to Suboxone by our MIH overdose prevention team. Because of a timing issue, we didn't have the correct information, or we weren't given by her the correct information. We ended up sending her into precipitated withdrawals. I was on the ambulance that was dispatched to that. Like I said earlier, it was dispatched as a psych run. En route, sorry, kind of doubled up on this information. I apologize for that. Like I said, because I'm familiar with the program, I think it was a little bit different. A lot of the guys in the field don't do the MIH kind of reserve role that I was telling you that I'm a part of, and so they don't have some of the information that I have. But because I do have that, I knew who I needed to contact on the MIH side of things and what the best kind of place to get the information was. I did call them, got the information, and that kind of got the ball rolling on our end to figure out exactly where this patient needed to go and what needed to happen when we got there. I was advised, like I said earlier, to go to UH versus any of the other hospitals, just because they have the bridge program needed for her to get the continuum of services and keep her kind of in our purview, in our way of helping her, I guess. List of substances. So she had been addicted to heroin. She might have had some others on board. We know a lot of those street drugs, sometimes they have fentanyl mixed into them, whether they know it or not, they do. And then methadone and Suboxone. What strategies do we employ? Like I said earlier, being familiar with the OPCR program, I contacted MIH to gather intel and to, I'm sorry, on the care plan for the patient. I took some tact in convincing co-workers and first responders who may or may not have been happy with the way everything was kind of being presented to them, and them not having the full spectrum of knowledge on what we do in this department outside of the 911 calls. So kind of having to share some of that info with them was necessary. Our agency's standard operating procedures. So providing emergency services, making sure the patient's vital signs are stable and they're not overdosing. We provide them comfort care and transport them to the nearest hospital or advise follow up with their doctor. We also refer patients with overdose issues or drug use issues to our MIH, the overdose prevention team. That way we can kind of try to get a head start with some of this stuff. Sorry, just trying to go through it. I know timing is an issue. Relevant context about the person. She was very anxious, unsettled, difficult to assess. When we found her, she was on the floor of the center, of the Beaver Health Center. She didn't even really want us to assess her at all. She's, I want to go to the hospital. I want to go to the hospital. Like, just get me out of here. Get me to the hospital. So it was hard to even get vitals on her. She was a polysubstance drug user, homelessness, no reliable transportation. She's dependent on shelters and assistance centers. Barriers to care. The detox center, which we assumed was going to be able to take care of her while she was in withdrawals, ended up denying her admission, which means she didn't get the care that she needed, or I guess while she was going through that, but that means they also didn't get interfacility transport, and that's why 911 was involved in the first place. On top of that, fire crews felt like there was nothing they can do for a patient that was maybe psychiatric in nature at a psychiatric facility versus if it was known to be an overdose at that point. Another one was my partner initially felt like transporting to the closest hospital was going to be better than going all the way to a different part of town. So having to explain the differences ended up being a barrier. And then the patient not meeting any of our specific transport criteria. We have certain protocols and criteria. I'm sure that other agencies do as well, that just kind of limit that these people must be transported. She didn't meet those, but just kind of based off of paramedic intuition, we felt like that was going to be best for her. So that's what we did. Yeah. And then, like I said, the hospital didn't feel like she was the right place to go for them, or they were the right place to go for her because they were so busy. So that ended up being an issue as well. And then a sixth one, which I don't have on that slide because I just added it, sorry about that, was that our fire and EMS system aren't particularly familiar with precipitated withdrawals compared to other types of withdrawals, and what ways to treat them. And so that kind of is an issue that's being addressed in our upcoming CE for this year. What went well for this encounter? It was good that there was at least one person on scene that had experience with the overdose prevention team. Otherwise, the patient might have ended up going to a less ideal hospital, might have even been left there. That way, that wouldn't have been suited her to her well. She might not have ended up being followed up with. She might not have gotten the care that she needed in the long run. Like I said, keeping her in the continuum of services, allowing the team to easily find her because she was where she needed to be. She ended up at a bridging program, giving her the best chance of recovery. We helped her feel like she was being helped and not being lost in the system. When we were there, she was kind of, I guess, not understanding why she was going through what she was going through. She thought, you know, Suboxone is this end all be all. Once I get it, I'm going to feel great. And so once it sent her into these withdrawals, she was like, I'm not doing this anymore. I don't want any Suboxone. I'm done. So we were just kind of trying to explain to her what was happening, why it was happening, and that there is an end to what's happening to this. And so we kind of kept her feeling like she was going in the right direction. And like I said, because I'm familiar with the team, I was able to explain to the ER nurses at the hospital that it wasn't just a regular patient who just needed to be seen and released. It was somebody who needed to get connected with a bridging program. What would I have done differently if I went through this scenario again? One of the things I didn't do was chat with our online medical directors. They kind of have more information on this kind of stuff, but because her vitals were stable and she was stable, she was stable enough for transport. We just kind of went with that, and I didn't call, but maybe I should have done that to know what kind of meds might have been good. We considered a couple, but because she was stable, we didn't end up giving her any. What do you think success might look for in this case? When she was going through the withdrawals, she was, like I said earlier, initial swearing off Suboxone. She didn't want to do it at all. She completely blamed the situation on just the act of taking it, not so much what she did or didn't do before taking it. But because we were able to get her into the right hands, I think success for me would be the patient changing course and giving Suboxone a fair shot, and keeping within the continuum and making sure that our team is able to continue getting a hold of her and not just kind of like falling off and becoming lost. And then for referrals, the way we do it with the San Antonio Fire Department is we kind of have automatic referrals for the most part. Anytime that our PCRs are narrative saying anything about overdoses, drug use, anything like that, it kind of red flags on the back end, and then our MIH is able to reach out and make calls and send teams out to their house to figure out what's going on. On top of that, we have the ability to one-on-one send referrals off to our MIH team, but that's what we do for those. On top of that, at the ER, just trying to make sure the doctors knew that this wasn't a patient who just needed to be treated and released, just make sure we knew where she needed to go after that. That's it I have for the case. Sorry if I kind of just stumbled through that, but I'm happy to take any questions or anything like that.
Thank you so much, James, for the presentation. I will open up the floor for any questions from our learning community here.
Well, I'll go ahead and chime in right now just to kind of give a large view of this patient. So this patient has been involved with 911 services here with the San Antonio Fire Department since 2018. Dating all the way back from 2018, there was a heroin use, and then there were some traumatic injuries where this patient was shot with a shotgun and was transported priority 1 to a trauma facility, where she, even during that time when she was transported, she was disclosing that she was on heroin. Shortly after that incident, she called again 911, complaining of chronic pain, possibly withdrawals, still complaining of stating that she was on heroin. So there's an outcry of this patient over the history that she's been involved with 911 services, that she is wanting some kind of help for heroin use or opiate use. It wasn't until 2024 when she actually did a self-referral. She called our program and asked for help. She told us that she was on methadone, and she was no longer having the capability of transporting herself to the methadone clinic on daily treatment, was looking for something that was going to be fitting more for her needs and her challenges, given that she doesn't have transportation and she is homeless. And so at that time, when she did come out to us to start Suboxone treatment, she did disclose that she was no longer using opiates, or she was no longer on methadone for at least 3 days. And so our criteria is typically, if we're going to be treating any patient with who was on methadone, we want them to be abstinent from that kind of treatment for 3 days. Unfortunately, when we did treat her, we started her off with 16 milligrams. It seemed like it was going to go well. And then after we left the scene, she ended up calling us back saying that she was in withdrawals. We returned back, did a full assessment. Dr. Miramontes went ahead and authorized another 16 milligrams. totaling up to 32 milligrams. And at that point, the patient was in withdrawals with no relief from a follow-up dose with that. And so at that point, this is when James kind of came into the picture with the 911 call after she had self-transported herself to a detox facility looking for help. And when he became involved. And so after the 911 call and she ended up going to the hospital, our doctor is very involved with any patient that we treat. We want to make sure that they're getting the full service from what we're providing for them. And so he did follow up with her while she was at the hospital, finding out that she was treated by the doctors over there who were familiar with the bridging program that the hospital and the clinic that we're all affiliated with on trying to keep her in that continuum of services and hoping that she would come back and continue with the Suboxone treatment. Fortunately, she did call back after her discharge, one of our MIH 24-hour groups. And the following day, when our team went back to engage with her again, she did disclose that within the less than 24 hours, it was probably just a couple of hours prior to us starting the induction of Suboxone treatment, she disclosed that she had used meth. And as we all know, most of these drugs on the streets are being laced with fentanyl, which is the reason why she went into precipitated withdrawals. So at that time, our doctor was a little reluctant about starting her on buprenorphine again, given that we're trying to bridge her into transition her from methadone to Suboxone in an uncontrolled environment. So he went ahead and gave her the ancillary medications, which is clonidine, Tylenol, Zofran, preparing her for induction the following day. So the following day after this whole incident with the 911 call had happened, we went ahead and did Suboxone treatment again, and it was successful. At that point, the team went ahead and made the referral over to the clinic, and a couple of days later, she replied back that she was in the clinic on Suboxone treatment and was doing very well. And so that's a big overview picture of what this incident. I don't think that this could have happened as successfully as it did.
Sean,
Yes.
I'm sorry to interrupt, but we are getting close to time. So I would like to invite the hub to give some of their comments and recommendations on these
Oh,
on this
absolutely.
case. Mhm.
Yeah, I'll open the floor for questions and comments.
Yes, please.
Well, one of my observations is I think that, and I've been out of the field a while, but I think that the participation of the EMS and the 911 staff are real involved in making sure that the safety of that person that they're dealing with is it's prime. And so, and especially the follow-up that they go into, as far as what I can see from this case example, is great.
I think we don't have a very good understanding of precipitated withdrawal, and I had some questions about the way it presented itself here. We don't have time necessarily to go into that, but I will say, going forward, like when there's buprenorphine involved and precipitated withdrawal occurs, just like take good notes, because I know I've talked to folks from Yale all the way to, the West Coast down to Texas about what precipitated withdrawal means and how it presents, because it is a big obstacle for induction into buprenorphine treatment. And so I think anytime we have somebody complaining of this like really severe buprenorphine related withdrawal, just like try to, if they're communicative, like understand what they were taking before this happened, how it came about, what they think like was the point at which they started feeling it, just because it's still a bit of a mystery, to be honest with you, how it presents and why. And what separates it from like just being on fentanyl and then not having your supply, right?
Jeremiah, I thought you had something to add.
I don't, because Brandon just covered it better than I could. I know we wish Dr. Miramontes could be joining us today too, because it would be he's got such a good knowledge of the from the medical side, as well as some of that operational side.
Joe, did you have any Any additional things to share about the case? Any comments?
Yeah, just quickly, I think, again, a kudos, and it makes me proud to hear the work that the San Antonio Fire Department does. And I think, James, again, it's awesome that you're standing up, advocating for the patient with your peers, with the nurses, with the hospital, and trying to make that transition as easy as possible. Because again, it's very difficult. And just hearing your partner talk about her being in the system for the last 6 years, it's easy to get frustrated and write people off. But again, you brought it up too. Like if EMS is saying like, oh, this is a psych patient, what are we doing? But it's actually like, no, she's like acutely dealing with substance use, and then your partner just throws in there that like, oh, and she was shot with a shotgun, so then we have trauma. Like that's a very complex case with a rich history that there is not going to be just like here's the solution that one time will fix all things. And so kudos to you for again seeing the person dealing with the trauma, trying to get to the root of this and not just trying to throw a band-aid. So yeah, well done all around.
Thank you so much. And Joe, if I could request you to please provide a quick summary of the session today.
Yeah, I think I just did. I don't have much more to add. I think, again, tying into what I talked about with ACEs and then bringing a real life case into play here, I think it's important to, again, remember some of those key tenets, which is no matter how frustrating the problem is, we're like all problems are assigned to people. And so as long as we're trying to look at people individually and not trying to solve solutions at the expense of people through them, because everyone has an individual criteria for what it is that they're going to need based on where they are in that moment. So we know that there is not one just pure fix for anything. And I think, again, James, the work you're doing is phenomenal. The San Antonio Fire Department does a great job of trying to advocate for and creating these teams that are progressive in their approach and also proactive instead of just simply reactive. And I know MIH, which I think I saw a question, I don't know if it was answered, but the mobile integrated health team does a great job of identifying our highest utilizers and trying to get them plugged into the appropriate services. So that's, I guess, my recap. Shreya, I don't have much more to add to that.
Thank you so much, Joe. And thank you, James, again, for presenting your case, James and John. And thank you all for joining our session today. As a reminder, to earn continuing education credits, please complete the post-session survey using the link in the chat. If you would like to present a case, so please email the BWell Texas team at cstat.utisca.edu. We look forward to seeing you at our next session on Thursday, April 11th at 11 a.m. Central. Thank you and have a wonderful rest of your day. Bye-bye.